Everyone, you are joining the SAMHSA SMVF Technical Assistance Center Crisis Intercept Mapping for Service Members, Veterans, and their Families, applications and updates. So we really appreciate you joining us. At this time, we'll go ahead and get started. So as I mentioned, if you had just signed on, my name is Dwayne France. I am the co-director of SAMHSA's SMVF Technical Assistance Center. I will be managing technical questions for these for this webinar. You will see that you have the ability to see the chat. We do have this as a question and answer. I see some questions already coming in, and I'll be managing the Q&A pod. That this is in reception mode only. We don't have the ability to have, we have a large number of attendees, so we won't be able to have live question and answer. So feel free, if you have questions for the panelists as we go through, drop those questions in the question and answer pod, and we will answer those to the best of our abilities. You will also be receiving a survey at the end of this and the ability to interact with the recording. Once we have it, you'll receive that when it's done. So at this time, I would like to introduce Stacy Owens, the Military and Veterans Affairs Liaison for the Center for Mental Health Services, SAMHSA. She is honored to have the ability to collaborate, facilitate collaborative efforts to improve the mental health of service members, veterans, and their family. Stacy has a long history of working as a public health advisor for the Centers of Mental Health, SAMHSA's Center for Substance Abuse Treatment, and also working as a clinical social worker at the VA and DOD. So at this time, I would like to hand it over to Stacy to moderate our webinar. Stacy.
Thank you, Dwayne, and thank you to all of you for joining us for today's webinar on Crisis Intercept Mapping, which you'll also hear us refer to as SIM. Next slide. Before we begin, please note that the content expressed in this presentation does not necessarily reflect the views, opinions, or policies of SAMHSA. Next slide. This webinar is being brought to you by SAMHSA's Service Members, Veterans, and Their Families Technical Assistance Center, which partners with communities, states, and territories to increase behavioral health support for the SMVF community. SAMHSA is the agency within the Department of Health and Human Services that leads efforts to ensure that mental health and substance use treatment needs of all Americans are understood, including the needs of the SMVF community. Next slide. The SMVF TA Center is a national resource that supports interagency collaboration between military and civilian stakeholders, provides a centralized mechanism for connections and sharing of lessons learned, increases awareness of and access to resources that support the behavioral health needs of SMVF, supports coordinated responses, and encourages implementation of best practices. Next slide. The SMVF TA Center offers training and technical support through various activities, including academies, crisis intercept mapping workshops, webinars like this one, learning communities, and technical assistance call series, as well as subject matter consultation and dissemination of resources. Next slide. Let's review our learning objectives for today. They include describing the crisis intercept mapping process for SMVF and sharing future opportunities for engagement, demonstrating how a coordinated statewide approach to crisis intercept mapping can enhance collaboration and improve SMVF crisis response systems of care, as well as sharing findings from a recent analysis of key takeaways from the results of crisis intercept mapping in 24 communities. Next slide, please. We're fortunate to have 4 subject matter experts presenting for us today. We'll hear from Richard McKeon, who's the Suicide Prevention Branch Chief at SAMHSA, Donald Harris, who's the Assistant Director at SAMHSA's SMVF TA Center, Brandy Jankaitis, who's the Director of the State of Virginia's Veteran and Family Support Program, and Brett Harris, who's a Senior Research Scientist with NORC. Next slide, please. First up, we will hear from Richard McKeon and Don Harris. Dr. McKeon is the Suicide Prevention Branch Chief within the Center for Mental Health Services at SAMHSA, And in his position, he oversees all suicide prevention activities, including the Garrett Lee Smith Youth Suicide Prevention and Campus Suicide Prevention Grant Programs, the National Suicide Prevention Lifeline, and the Suicide Prevention Resource Center. He's also served on the board of the American Association of Suicidology and participated in the development of the World Health Organization's World Suicide Prevention Report. Additionally, we'll hear from Don Harris, who's the Assistant Director at the SMVF TA Center at Policy Research Associates. In his role, Mr. Harris works directly with state and local interagency teams to support strategic planning and implementation that strengthens the behavioral health systems that serve the SMVF populations across the nation. Early in his career, Mr. Harris served as a unit leader in the United States Marine Corps, and he is a combat veteran. So Dr. McKeon and Mr. Harris, I will turn it over to you.
Thank you. And Stacy, you'll be able to advance the slides?
Yes, Dwayne is advancing those. Just say next slide when you're ready.
Okay, great, thank you. So let me start off by mentioning a couple of things this slide says crisis mapping supports National Public Health Agency. The president issued an executive order probably about a year ago. It included a number of different components in that executive order. And I'll touch base on that in a little bit more. But one of those elements of the executive order was the expansion of SAMHSA's crisis mapping initiative to be able to assist cities and counties in identifying gaps and incorporating best practices in suicide prevention for veterans who interact with community crisis systems. And this is important for a number of reasons. While the VA has a wonderful system, with a world-class crisis center, with the Veterans Crisis Line, with a well-designed and research-based effort to connect veterans who go to veterans emergency rooms with care, the likelihood is that the majority of veterans who are seen in emergency rooms across the country are seen in community emergency rooms. And if they're seen by a mobile crisis team, it is most likely that it is a community mobile crisis team. And then there are also many veterans who choose not to press 1 to be connected to the Veterans Crisis Line and go to community crisis centers. So we can go to the next slide. So SAMHSA and the Center for Mental Health Services has been pleased to be able to support crisis intercept mapping going back to 2018. And this really has two major components. And this is very much an initiative that focuses on localities, either counties or cities, to help them go through a planning process to identify whether they have the key components available in their crisis system, whether those key components are able to coordinate with each other, and whether they are utilizing best practices. And what you see here is the 67 community teams that have been engaged in crisis mapping over the years. It really started small in 2008. And notice one of those is Richmond, Virginia, and Brandy will talk to you more about their experiences and the wonderful things they have done since then. And this also includes those that we have engaged in 2022. Next slide. So it's important that crisis mapping addresses opportunity that are across the crisis care continuum. And this is particularly important with now the universal availability of 988 by chat, text, and phone. And at a time when SAMHSA is really prioritizing trying to build a comprehensive crisis continuum. So this is an opportunity. It is a tool to help communities be able to identify whether they have the elements of that comprehensive crisis continuum in their communities and are utilizing the best practices. So that means engaging whatever partners exist in the community, as well as identifying those who might not. So here what you see is, some of the various kinds of community engagement that can exist. Obviously, 988 as one resource. Also, specially trained law enforcement as a backup for those times when it's not possible, for example, to send a mobile crisis team without law enforcement. And then 911 medical response, emergency medical services, access through the 911 public safety answering point. And then really we try to engage the full range of crisis and acute care services in these opportunities. And here, one thing that's very important is the TA Center's ability to work with stakeholders and to convene them together for this work. Next slide. So this gives you a sense of, and I won't go into detail on crisis intercept mapping, but it's built on some of the great work that our colleagues at PRA and the Gaines Center did in intercept mapping in the justice system. This is really trying to apply that to the crisis systems, going from first contact to acute care. And then you see Intercept 3 as care transitions, to be aware that the crisis doesn't end after the phone call, after the mobile crisis visit, even after the emergency room visit, and that there's a need to continue contact till we know the person is safely connected to the care that they need, which is Intercept 4, the ongoing treatment and support, recovery support. Next slide. Of course, this is happening at a time when, of course, there's an ongoing concern about suicide in America. But there are a number of reasons for us to have particular concern now, regarding this issue. Nearly 46,000 people died by suicide in 2020. Over 12 million adults 18 and over seriously thought about suicide. 3.2 million made a plan. 1.2 million attempted suicide. And this is just 18 and over. So for those younger teenagers, the numbers, would go even higher. And so this is why, among other initiatives, SAMHSA's 988 and Suicide Crisis Lifeline is particularly important to be aware of and to utilize there. And as you can see on the slide, be available by call or text to 988 or by chatting at 988lifeline.org. Next slide. So one reason that I said this is particularly important now is that tragically, the provisional numbers released by the CDC on suicide in the United States in 2021 showed a 4% increase compared to 2020, higher for males than for females. And in fact, for males aged 15 to 24, the increase was 8%. So a significant concern. You can see in the slides, um, one slide compares the provisional 2021 data to the final 2020 data, and you can see that in most months, the provisional 2021 data, unfortunately, was higher than the year previously. And the second slide is a bar graph that again shows the comparison between 2020 and 2021. The 2021 suicide data is not quite as high as the high point that was reached in 2018, but unfortunately, it is higher than 2019 and 2020. Next slide. And we know on an ongoing basis that there has been a gap in the suicide rate between veterans and non-veterans. And these are the adjusted rates, so where you can see that, comparison. So there are many reasons for us to be concerned about suicide among our nation's veterans, as well as among their active duty service members and their families. But one of them is the higher rate of veteran suicide compared to non-veterans. Next slide. And then the other reality is that most veterans do not access the VHA for health care. So the estimate is over half of the 19 million veterans across the country do not access the VA for healthcare services. And so that means that, well, even while VA has a sterling suicide prevention program and many model programs, they can only benefit the veterans if the veterans are connected to VA care. So another key piece of our efforts is some of the programs that VA has shown to be effective. We're trying to expand across the country. Next slide. So this shows you the typical crisis response flow that we often see, this in particular, when someone calls 911, the 911 PSAP makes the connection to either emergency medical services or to the police as needed. But then this also at times can lead to incarceration and to being brought to the emergency department, where unfortunately long waits are all too common, typically waiting for a hospital bed for inpatient psychiatric care. It is for this reason that the use of 988 as an alternative to 911 is important, because while there are many times where the police and the EMS need to be engaged, there are other times where that is not necessary. And so we are working both on diversion from 911 to 988, as well as protocols for transferring from 988 to 911 in those instances when that kind of response is needed. For example, we estimate that less than 2% of the times that the lifeline is contacted, this is needed. The majority of those, however, are suicide attempts in progress. Next slide. And partners in emergency departments play a critical role in the process. Said ED presentation significantly associated with substantial increased risk of suicide and other mortality during the year after presentation to the emergency department. Is that for suicide attempts, 56 times greater, for suicidal ideation, 24 times greater. It's for this exact reason that the president's executive order had a real focus on this as well, and expanding the kind of model program based on data and scientific study that VA is using to provide screening, safety planning, and then follow-up to those seen in VA emergency rooms, to expand that to community emergency rooms around the country for the benefit of our nation's veterans, but also for the benefit of all Americans. Next slide. And I believe this is where I'm turning it over to you, Don.
Thanks, Dr. McKeon. I can definitely take it from here. And I appreciate you providing that big picture of why really the crisis intercept mapping came to be and why it's implemented nationally. So this particular slide speaks to some of the impetus that's driven for why this is focused at the community level, specifically among those civilian providers or non-military connected, non-veteran connected providers. These graphics just represent some of the data that was collected from a RAND study that many of you may be familiar with that took place years ago. And it really looked at military cultural competency among mental health providers from 3 different settings. The leftmost really representing those who are in military settings and military treatment facilities, VA, medical centers, et cetera, where 70% of those providers report having high military cultural competency. Next, that middle graphic represents those different providers that are within the TRICARE network. So we see about a quarter of those folks. And then lastly, we can see less than 10% of providers that are neither military, TRICARE, or VA connected consider themselves to have high military cultural competency. So this is a large reason why working with community providers, considering that a majority of veterans across the nation do not access the VA for care, why it's important to work with these folks in the community. Next slide, please. And as Dr. McKeon described the why, the big picture behind why this is being driven, I'll just talk just for a second about how it's implemented. So Dr. McKeon gave the broad goal of crisis intercept mapping, and really it's broken down into 4, or I'd say 4.5 objectives. Starting with looking to assess those gaps and those opportunities that exist across the community as it relates to suicide prevention for SMVF. And we do that systematically in a number of ways in this process. Another one of the goals is really to strengthen some of those partnerships between the providers, those that provide support for veterans, and the community stakeholders that are relevant, have authority or responsibility to work with these populations across the community. So we want to strengthen some of those partnerships by bringing them together through this process, and then really institutionalizing some of that relationship bonding, that collaboration between these partners. Thirdly, to support the implementation of best practices. So Dr. McKeon alluded to this earlier on. Looking across this model, and I'll talk about how this model is broken down for some of you that haven't been involved in crisis mapping in just a second, but looking to support best practices where they are most relevant across the community. As you look at this model, you'll see 4 broad blocks, vertical blocks. Those are intercepts, as we call them. The first one being first contact, probably the widest spectrum of community stakeholders, including higher education, law enforcement, could be primary care providers. Understanding what's happening in each one of these intercepts is critical. And this one is probably in the best position to identify those folks that may be at risk of suicide and screen for military service history. So those best practices, looking to see where those could be implemented and ensuring that there's high fidelity where it is currently taking place. And then where those folks may be able to refer to, moving to that second column, acute care, Intercept 2, which is the reddish column in this model. And those are the folks that deal with treatment and stabilization of folks who are in crisis. Your mobile crisis units, emergency departments, inpatient, crisis stabilization units. And understanding those folks, whether or not those folks do have that military cultural competency training, because that's important for that connection with patients who may be veterans or have served in the military, whether or not safety planning is taking place in some form, and whether or not those folks understand how to discuss lethal means safety, have the comfort to discuss it, and also the means to discuss it. Moving on to that critical mustard yellow colored Intercept 3, which is deemed care transitions, is that safety net space. So this is a lot of times where veteran peer organizations can come into play. We can also have care coordinators in place here. Implementing a care and context protocol is valuable as well in this space. Another best practice that can be implemented at the local level. And then finally, that long-term treatment and recovery supports, in many cases can loop back around to Intercept 1, but it includes a lot of those stakeholders in the community that tend to focus on those social determinants of health. So employment, housing, et cetera, and ensuring again that they have all of the resources needed to help ensure that someone maintains that level of stabilization. Looking again at the left side, that fourth bullet, we do this by helping to develop a map of the relationships between these stakeholders. That map is itself a tool, and it's used to help with this action planning that takes place through this process of crisis intercept mapping. So that at a very high level is what the objectives are of crisis intercept mapping, and we work through it systematically with community partners at the county, city, and local level. Next slide. What we have taking place currently is a solicitation for applications to participate in crisis intercept mapping workshops. That is running through the end of this month. November 30th is the due date for applications. So for folks that are online, and as I'm looking through the list of attendees for this webinar, I recognize some names. So I know some folks are familiar and some folks may not be familiar, but if this sounds like something that would be beneficial to your partners at the county level, at the city level, local level, within different communities, reach out to the SMVF TA Center. We'll definitely provide that contact information, or reach out to your state liaison at the SMVF TA Center to find out how those folks can be connected and submit an application for this. So I think at this point, I will turn it back over to Stacy to talk about the phases of the process, and then share a little bit more about how this has been applied at the community level. Stacey?
Hey, thanks so much, Don. So in terms of the crisis intercept map phase process, in phase 1, we give an orientation call and assess the needs of the new teams. And then we assist with the data collection process, transitioning over to an interfacing module 1 and module 2, where we assess for gaps and obstacles, and then transition into looking at goals to address those. In the second phase, we take teams who have successfully completed phase 1, and for phase 2, we revisit the map that they created during phase 1. We work with them to update and finalize their goals. And then we specifically work on developing measures and metrics for success, because outcomes is really what we're focusing on here in terms of closing these gaps. We help them to identify any key drivers that might be present within that gap analysis, and really identify the who, when, where, and how to address. And finally, we focus on planning for sustainability, because we want this map to be a useful tool that communities can use in continuing to bolster and support their crisis systems of care. Next slide, please. All right. So we are going to transition over to Brandy Jankaitis. Thank you so much, Dr. McKeon, who unfortunately had to step away for another meeting, but we appreciate Dr. McKeon and Mr. Harris for their input on this topic. All right, so again, we're going to transition over to Brandy Jankaitis, who is the Director of the Virginia Veteran and Family Support Program within Virginia's Department of Veteran Services. This is a statewide program that provides peer and family support and behavioral health and supportive services, linkages to military service members, veterans, and their families. Brandy also leads the efforts around Richmond's Mayor's Suicide Prevention Challenge and their statewide Governor's Suicide Prevention Challenge teams. She previously led Virginia's efforts to address veteran homelessness, and she herself is an Army spouse. And Brandy, the floor is yours.
Thanks so much, Stacy. So just want to do a quick audio check. Everything coming through okay? All right. So jumping in here, really appreciate the opportunity to talk to everyone. And I cannot tell you how excited I am that there are 300 participants plus on this line interested in such a neat model that is crisis intercept mapping. And I'm going to give you a whirlwind tour of what Virginia's journey looked like, and then some takeaways at the end. So we can go ahead and get to the next slide. So I'm hopeful that there are some Virginia communities represented, whether they were past teams, which we'll do a tour through in the presentation, or your prospective teams. I can promise you that the Richmond Mayor's Challenge team, as well as our statewide work with the Virginia Governor's Challenge, we want to be a support to you if in some way your organization or your crisis mapping journey will include services to military connected citizens in the Commonwealth. Please keep us posted. And to any current team members that are out there, thank you so much for joining today. And we could not do this work without all of you. I'm fortunate to be one of the worker bees that keeps things moving forward, but couldn't do it without our federal, state, and local partners in and around the Commonwealth. So we were fortunate to start our Richmond Mayor's Challenge journey and our Governor's Challenge journey in the first cohorts of those call to actions from our federal partners, VA and SAMHSA. And we started those journeys in 2018, and we have successfully transitioned from one administration to our newest administration. And we have our teams at the state level are led by the Secretary for Health and Human Resources and the Secretary for Veterans and Defense Affairs. So you have a nice merger of SMVF specific agencies like our Virginia Department of Veteran Services and mainstream human services agencies. Next slide. All right, so we have been fortunate to use the SIM model multiple times in Virginia, going back to 2018 with that Richmond Mayor's Challenge journey just kicking off. We were a couple of months in to that call to action when we were able to launch the SIM model, and then all the way through just a few months ago. So let's jump right in and talk about how these communities used it as a planning tool to spur local action. Next slide. All right, so our Richmond Mayor's Challenge team really jumped in and focused on the Ask the Question portion of our priorities for the Mayor's and Governor's Challenge work. And what that means is identifying military connected individuals that they were engaging with. And we really honed in on support to first responders and law enforcement. And we were able to develop a business card resource card, which had the Veterans Crisis Line on one side and the Virginia Department of Veteran Services Peer and Family Support and Care Coordination Program on the other side. So the way that first responders and law enforcement used it, when in crisis, Veterans Crisis Line, everything else other side. And really, of course, if it was an active concern for safety, then they're trained to respond in ways to get someone to safety and stability. But most of their calls it was a situation where you knew that if something didn't change for the family, access to care, supportive services, that they were going to be back and things were going to be worse. So the card was designed as an outreach tool to get connected to resources before the crisis. And we have since taken that resource card and really expanded it statewide into multiple services sectors. This was the first team that also used their SEM model to really actively map referral flow charts. One of the things the team wanted to work on, and you'll see a common theme through all our teams, is they wanted to work on how to get mental health and behavioral health referrals into their local VA treatment facility, whether it was a big hospital, a medical center, a local vet center, or another treatment facility. How did referrals work? You know, baseline mental health and behavioral health referrals all the way through a crisis referral. And they mapped that process out with this model. And that was something that the other teams were able to benefit from as well. And then they were able to coalesce around advertising resources for service members, veterans, and families in their region. And the site's there on the slide for you. And the team took their action items and integrated it into the annual VA Mental Health Summit. So these are just a couple ways that they bridged partnerships and advertised their services to different stakeholders here in this first iteration, which was back in June of 2018. Next slide. We can skip forward. That was what the business card looked like. And this iteration is now going to be replaced with 988, which got a lot easier than the 1-800-273-8255. Now, for those of us that advertise the Veterans Crisis Line on a regular basis, it got a lot easier with 988. Next slide. All right, and then that brings us to Hampton. So we're moving from Central Virginia, our capital city, our mayor's challenge city, to more towards our coastal area in Hampton. And the unique thing here is that our area VA Medical Center serves a very large regional area here on the coastal part of Virginia. And so having that community and Hampton VA-led team was really important. It bridged community and local, and then VA partnerships. And as I said, with the Richmond team, this team mirrored that referral flow chart process. And then they dug in on two key initiatives, utilizing the military culture training through our Virginia Department of Veterans Services, which because of these efforts went from piecemeal training requests where, you know, we just provided training to providers as needed, to a monthly webinar offering where we could funnel SIM, Governor's Challenge, and other stakeholders into those regular military culture trainings offered by our agency. And then this Hampton team dug in on lethal means safety, or putting time and space between the means that someone might die by suicide, such as a firearm. And so securing firearms early and often before a crisis, and particularly when behavioral health symptoms are present or suicide risk is present. And we had an existing lethal means safety initiative called Lock and Talk Virginia, and we were able to use the crisis intercept mapping team activities and broader Governor's Challenge activities to bring the service member, veteran, and family focus into Lock and Talk Virginia. And just an example of this has come so far since 2019, and local communities have really embraced this. In November, we did a specific caregiver focus for Lock and Talk Virginia through our local public mental health center. So this activity continues into today. Next slide. All right, now we're going from the coast all the way to the western part of Virginia. So what you're getting here is in the Radford area, you're getting a more rural audience. And so the focus changes. You deal with issues such as transportation barriers. You could have to travel 2+ hours to get to any treatment facility, whether private, VA, or public. And so they really dug in on transportation gaps, access to care initiatives, and National Guard focus is also really heavy in rural communities. You have local units. And so making sure that the non-military and veteran-specific agencies like your public mental health centers, your private providers, mainstream chapters of NAMI or Vocal or peer supporters, that those organizations knew how to do outreach and support to the National Guard units and bridging that. We're also fortunate in Virginia to host a VA national program called Together with Veterans, which is veteran-led suicide prevention through opportunities that expand outreach and suicide prevention training in communities. One of the outreach events they use are art therapy events hosted by local peer supporters. And so we're very fortunate to be able to host that national program. And the door opened because of crisis intercept mapping and our broader Governor's Challenge journey. Next slide. All right, so one of the activities that any crisis intercept mapping team could be a part of was our Whirlwind Military Culture and Suicide Prevention Summits. So these were, notice the year there, 2019, when it wasn't as complicated to host large in-person gatherings. And so we launched these whirlwind tours, and at each one, we had a focus on the VA SAVE, or the Gatekeeper Suicide Prevention Training. We had our VA Suicide Prevention coordinators teach on lethal means safety, and then we had regional resources represented. And these were very successful, and in large part because our crisis intercept map teams could do the recruiting for this and could tie their efforts into the summits. Next slide. And next up is another initiative of the Governor's Challenge that crisis intercept mapping teams integrated into their work, and that was the VISOR pilot. Virginia's Identify Service Members, Veterans, and Families, Screen for Suicide Risk, and Refer for Services, or VISOR. The goal of the VISOR initiative is to tie into the Governor's Challenge priorities, which are to expand military culture, suicide prevention, and safety planning infrastructure in community agencies, and to ensure that we expand risk screening in community agencies. Initially in 2020, when we launched the pilot, we had 40 agencies sign on. About 19 were able to contribute data at the end of their experience, and we'll go to the next slide and take a peek at some of that data. So what you're looking at here is the different sectors for the community partners on the axis, as well as their screening rates. So what you're looking for here is, of course, universal screening. So by being able to talk to community behavioral health agencies, departments of social services in the VISOR pilot, we were able to show them of the total SMVF they served, here's the percentage you were able to do a suicide risk screening on, with the idea that we provide technical assistance to inch them closer to universal screening or 100% coverage. So you can see how VISOR, with that focus on identifying, screening, and getting into the key resources at the different intercepts in crisis intercept mapping, why the VISOR initiative would be such an important tool for teams around the state. Next slide. And Suffolk, next to last team. So back to the coast in March of 2021, the Suffolk team indeed used the VISOR pilot activities that I just spoke about that tie to those Governor's Challenge priorities, and really engaged local schools and the local military installation. And this team was particularly strong at engaging hospital settings. So bridging VA Medical Center, private hospital, and state psychiatric hospital cross referrals. When they went into this journey, it wasn't a smooth transition process. And by coming to the table, mapping that, they were able to bridge that communication. Next slide. And our final team, recently, as a couple of months ago, we're so thrilled that our Northern Virginia area, Arlington and Alexandria, so just outside of the nation's capital, they were able to launch, or so early days with that crisis intercept mapping journey. And they're jumping in on asking the question, identifying this population, training in military culture, using Visor to encourage risk screening expansion in community agencies, and then really tying in peer support to bridge those care transitions. So moving from not sure where to start to access care to getting into VA or into community and back again through that veteran to veteran peer support. And also I want to highlight a special role that our public mental health centers have called a service member, veteran, and family navigator, or an SMVF navigator. So that individual representing the public mental health centers in the region was a key team lead to be able to rally both mainstream and service member and veteran family stakeholders together. So often with this journey, it's about finding capacity in places that can help you launch crisis intercept mapping, but most importantly, continue it after that initial mapping phase. Next slide. And this is my final slide, talking about a few lessons learned. What I don't want you to do is hear this activity and be like, well, that's a lot. How will we ever get there? Because it starts with one community, right? It starts with a few stakeholders around the table using this very helpful model in the crisis intercept map, digging in, getting the map, and then getting the others you need at the table to close the gaps. And I can promise you the model will support you. So whether you're a seasoned team like us or you're just getting started, the crisis intercept map team model can support your work. We found success with VA and community co-leads, as well as peer support, kind of bridging the different intercepts, and then tying our activities into Mayor's and Governor's Challenge broader initiatives. Because they were already there, they were related, and it was easy tie-in for these local teams. And at the end of the day, keep it flexible and feasible. And that's it. Thanks so much, Stacy.
Thank you so much, Brandy. We really appreciate that timeline that you provided of how these interventions happen throughout the state over time and how you all phased up your efforts within the state by bringing together those communities and mapping. Also really appreciate the discussion of lessons learned as well as conclusions. The beauty of the Mayor's Challenge and the Governor's Challenge and SIM all working together is that it really provides an opportunity for states and communities to share with each other and learn from each other. So thank you for being willing to share and letting others learn from you. All right, so we will transition over to Dr. Brett Harris. She is a senior research scientist in the public health department at NORC. And in her position, she leads a suicide prevention research portfolio. Dr. Harris is also the president of the New York Public Health Association, and she's authored or co-authored 20 peer-reviewed publications that have appeared in numerous academic journals and other media outlets. And we appreciate her being here to break down some of these key takeaways from STEM workshops. Over to you, Dr. Harris.
Great, thank you. And I feel like this was the perfect lead-in. The work that's being done in Virginia is really tremendous, and you can see that just the importance of this work, the SMVF TA Center and the SIM process, and how that can carry communities along to really build the crisis infrastructure. So the SMVF TA Center has been doing, as you saw earlier, been doing this work since 2018. And they were thinking, wow, like we have a lot of information, and they think that this information could be really useful in really demonstrating the current state of the crisis care infrastructure. So they pulled in NORC and my team that you could see here on the slide to do an independent analysis of the information that's been collected. Next slide. And next slide. So as you heard, it was going on since 2018, and we used information starting from 2020, so 2020 to 2022. And really, before we get into the results here, just what do we get out of this information? And a lot of it pertains to right now, because 988 is on, the tip of everyone's tongue. And SAMHSA's goal really with 988 was to increase access to crisis care services, as well as utilization of the number, making it easier to remember. But of course, as call volume increases, we need to have that crisis care infrastructure available at the community level. So that's a long-term goal of SAMHSA's. So what we can tell here from this work is what it looks like right now at the beginning of these sessions. And then you can see the great work that Virginia's done through this work to improve their crisis care infrastructure. So we looked at 24 specific communities that took place between 2020 and 2022. And these ones were included the TA sessions as well as the data collection tool. So next slide, please. So you can see it's both quantitative and qualitative analysis. So I know that the CIGT was mentioned earlier. That's the community information gathering tool. And it was administered to organizations prior to the TA session. So 272 organizations responded. So we had 24 communities, and within that, this tool was distributed to multiple organizations. So you could see that there's far more respondents to this than communities themselves. And the topics were a bunch of topics talking about when veterans are kind of in touch with the system, who's screening for suicide risk, both protocols and actually delivery, training completion by type, suicide prevention protocols, and collaboration. And then the qualitative piece is really taking the notes and the session summaries from the 24 communities and the different modules that they participated in. And we identified some main themes that map closely to the intercepts as part of this whole process. But we're going to go over them one by one. So we're going to include identify and screen, safety planning, lethal means safety, and supportive contacts. Next slide. All right, so before I get into the results, I just want to outline something, and some of you might be familiar with the literature and with the zero suicide model and elements of suicide care. And a lot of the work that's done here, we know that services aren't provided at the level that we hope they are. And these studies and evaluations are typically done at the health system level or multiple health systems. This particular analysis, we're looking at the community level, so we can see the bigger picture. So when we talk about a community, we may be talking about multiple health systems. We might be talking about community-based organizations, agencies, and other potential touch points within a community. So this will help give the infrastructure a little bit more detail about where we are and where we need to go to support the 988 rollout. Next slide. So the first we're going to cover is identify and screen. And on the top left corner of each slide, we're going to map it up with the Intercept. So this is first contact. It's really critical to identify both SMVF, the status, so that we know to provide them targeted services and resources, and also to be able to identify suicide risk. And I know, I peeked at some of the questions, and I know people were talking about upstream work. Identification is really critical, and that if someone could be identified at low or moderate risk, it's still an important opportunity for more upstream prevention, and then could be identified at high risk where they go into acute care. So the communities talked about a number of gaps and challenges, and just big picture, again, like we hear, there's a lot of work that needs to be done at the community level. It's no surprise, but also what's promising is that there's multiple opportunities and solutions that have been identified by communities that are tangible and can be completed. So I think this gives us a nice map for getting us to where we need to be. So regarding identification screening, according to the quantitative CIGT, 73% of organizations ask an identification question for veteran status. So that's usually the ask the question that was mentioned earlier. And then 64% screen for suicide risk. So just an important note that the tool asks about screening. They asked about screening using a specific tool, and then they asked about which tool is being used. So even though 64% indicate screening for suicide risk, just about half, or actually a little bit less than half, said that they use a specific screening tool. And among those that use a specific screening tool, about 3/4 use the Columbia screening tool, which is one of the most widely used screening tools for suicide risk. Some of the other communities reported using the PHQ-9, which is mostly a depression screening tool. And then they also talked about, of course, using the Ask the Question tool. So the gaps were the lack of established and consistent protocol for identification and screening, and then limited knowledge and confidence in screening. So I think this doesn't surprise us, because a lot of the research out there shows that so that self-efficacy itself is really tied to practice, so that we need to build knowledge and confidence, and also those formalized processes. So increasing education and training, and then improving coordination among veteran service organizations, so that we can make sure that we have both of the identification and screening questions, including Ask the Question for veteran status, as well as a suicide risk screener. Next slide. So jumping to safety planning. So this is Intercept 2, acute care. And safety planning, if you remember from the crisis intercept map that went over the 4 different intercepts, safety planning was listed as both as Intercept 2, 3, and 4. So I'm going to talk about really all of the issues related to it, rather than waiting until we get to Intercept 3 and 4. But safety planning is a really critical element of suicide care, and it helps to provide individuals with a set of coping strategies so that they can cope with a suicidal urge and on their own within the community that is time limited. So there are a number of challenges that were identified to doing safety planning, which resulted in low implementation of safety planning. So you could see on the right side of the slide, about 42% organizations have a safety planning protocol in place for high-risk SMVF. So this is lack of established and consistent protocol for safety planning. Again, limited confidence due to lack of training, and then lack of standard definitions for safety planning. So if just generally speaking, when people say safety planning, it's not necessarily the evidence-based Stanley Brown safety plan. It could be really anything like a general crisis plan. But the issue with that is that the triggers and the coping strategies for suicide risk could be very different from substance use, domestic violence, anything else. So there's this. So it was unclear through the TA sessions that the definition when a community said they were doing safety planning was actually the evidence-based one for suicide prevention. Regardless, it was only 5 of the 24 communities that said that they had a protocol in place for safety planning. And so the opportunities and solutions that were raised was training a whole group of different types of professionals like law enforcement, justice system staff, and faith-based organizations, and ensuring that all parties are aware and agreeable to their role in the safety plan. So, the first bullet, it's important that these individuals, they can come into contact with people that could be in crisis to be able to check in on the safety plan and encourage its use. And also when someone is put on the safety plan listed as a contact, it's really important that they know that they're on the list and that they're agreeable to be participating in this role. The other piece that I just want to mention about safety planning is that it's really important that providers, when this is delivered, it's done as a collaborative brief intervention. So the information that was provided in the TA summaries was really showing us that it was more, some of the communities were using it as a form. So like completing a form and filling it out rather than the collaborative safety planning intervention. And that's where the evidence base is, because it's really important to develop a rapport with the person and to really kind of go over what the practical steps that they could use to put on that plan and what the barriers are to carrying it out. And this is really supported in the research because there's been studies out there. One of them in particular was a chart review that there's really only evidence in 30% of the safety plans that there was any form of collaboration. And then the safety plan needs to be continually reviewed and revised. And it's not clear that that was done, as I'm going to get into on a few different slides later on, that having that follow-up is really critical. And again, like the research says, that only about 10% of safety plans are really ever revisited. So safety plan, like if someone is at risk of suicide and they have to use that safety plan, it's very possible that they said, well, that was not helpful. I really should change this to pick something that's a little bit more practical for me. And it's going to be helpful to me in time of crisis. Next slide. So lethal means safety, also part of Intercept 2 was another key issue that came up. And again, like we're seeing a drop off in the utilization of these different practices. So we have about 40% of organizations offering lethal means safety counseling to SMVF. This is a key part of the safety plan itself, the Stanley Brown safety plan. And those that were doing this, that their strategy was to integrate it into the safety plan, which is, it really is what it's a part of. So the gaps and perceived obstacles that were mentioned was a lack of training for providers. Again, we know training is critical. Limited knowledge and understanding of the importance of firearms within the SMVF culture. And you'll see that like military cultural competency was really key as we get a little further along in the presentation. And then there are specific policies out there, it's really state dependent, that create hesitancy among SMVF. So to admit that they have a firearm, or to utilize like buyback programs, or to even temporarily store or give their firearm to someone else in the event of a crisis, they were hesitant to do that because they could, for example, they might need to have a background check when they want to get their firearm back. Or they could risk having, if the firearm is unlicensed, they don't have a license for the firearm, what the consequences will be. So the communities outlined a few opportunities and solutions, including raising awareness of SMVF culture and firearms, and also partnering with gun shops, ranges, and law enforcement agencies to implement lethal means safety efforts. Because we know how important it is to have the community itself providing the messages so that it's well received. Next slide. So Intercept 3 and 4, we're going to cover together on supportive contacts. And there's really a lot of information here. So we broke it down a few different ways. So follow-ups and caring contacts, crisis care, peer support services, and referring and connecting SMVF to resources. So what I'm going to say before I start here is that we covered Intercept 1 and 2, some good practice going on, but definitely some gaps and areas for improvement. There's a big drop off when you get to follow-up and care transitions, because just generally speaking, it's more difficult to carry out something when someone is no longer in your care. It really takes a lot of collaboration. So I don't think it's kind of understandable that it would be more challenging, but a big area of need. Next slide. So starting with follow-ups and caring contacts. According to the CIGT, 20% of organizations have a protocol in place to provide caring contacts to SMVF at risk of suicide. So I know we have like almost 300 people on right now. I don't know who's familiar with caring contacts, but they really are, it's a simple message of caring that comes from the organization upon discharge to show that you're there and how to contact back if they need anything. And it's very a simple way to have a big impact. The research does show that this has an impact simply sending a postcard or a text or an email. So the communities mentioned a number of gaps and obstacles, but having a lack of a health system policy and protocol for this, And then just basically, there were some communities that were implementing zero suicide, and they just said that they left the transition element out. This is really important again, because like the highest risk period is in the 72 hours after discharge. And we talked about like a week after discharge. I think it's like 300 times the risk of suicide. It's like 200 times in the month after discharge. So it's really critical that a number of measures be taken upon discharge. But the communities did mention a few opportunities and solutions, including forming partnerships and developing protocols that facilitate follow-up care, and then also helping parties understand the guidance provided to SMVF upon discharge. So I think one of the key issues that came up was that SMVF don't really know what to expect after their discharge, so make sure that they know and can get connected to ongoing care. Next slide. The crisis care and peer support services. So crisis care, there were actually the fewest obstacles and gaps listed for this, but communities did say that there is a lack of crisis response units in many communities, and that some of them said that mobile crisis units were not covered by Medicaid, which was a big obstacle. But they also mentioned that there's a few ways that opportunities to address this, including developing formal interagency agreements for post-crisis intervention, and also engaging in efforts to support and promote the 988 Suicide and Crisis Lifeline. So a bunch of them did say that they're getting involved in those efforts or want to get involved in those efforts. Peer support services was also key in that, but there were a few specific gaps that were mentioned multiple times, and one of them was that peers are overstretched. The other one was that peers require a certain level of supervision, and those who would be in that supervisory role are lacking. So there's a workforce issue, and some of those, like for example, have to have a certain level of education or credential, and there aren't enough of them to supervise the peers, so that the peers can get the hours they need to get their certification. A few opportunities and solutions were mentioned, including adding a peer advocate specialist to community VA clinics, and also using 211 to connect SMVF to peers. They also did talk about having peers at certain trade shows, or like gun shows, like at different booths. That was also mentioned. Next slide. So for referring and connecting SMVF to resources, there was a lot of talk just about, really across the board, about lack of communication between organizations and the challenges of implementing warm handoffs. They just mentioned either a lack of protocols and or administrative barriers, which really keyed in on the importance of developing standard policies and procedures for follow-up and improving communication lines. So they really stressed that a lot of times there was really no communication between acute and ongoing care, and that needed to be improved in order to be successful in referral and care transitions. Next slide. So collaboration is really key. And I really want to just emphasize that I mentioned earlier that there's literature out there on the implementation of suicide care and health systems. And what we don't see a lot of in those studies is what happens after discharge. So we don't know, a lot of what we were just talking about, or about collaboration. And this is something that this really adds to the knowledge base. As we know, collaboration is really critical for care transitions, and care transitions themselves are critical as this is a very high risk period for our individuals who are at risk of suicide. So what is a facilitator of collaboration? And we heard pretty frequently in these reports that organizations are more likely to collaborate if they have shared goals and they're dedicated to preventing suicide. So also knowing what the organizations are that do this work and that have these goals in the community. You think about your own community. I was doing this the other day, and I'm in the suicide prevention field. I don't know all the resources in my own community. So you can imagine how these different organizations struggle to identify collaborators. So it is really important. And this whole process brings that opportunity to do that in a setting that that's fostered by the SMVF TA Center. Cross-agency communication is really critical, including meetings and interconnected electronic health records as well. Many obstacles were mentioned. Again, like I'm talking about lack of awareness of resources and services available in the community. We all, fall into working into silos as well as communication issues. So I just want to mention quickly that we looked at the average number of partnerships across the intercepts. Intercept 1 and 2, there's about, on average 8. But then when you get to intercept 3 and 4, it drops way down to about 3. So we could see that there's much more work required in this specific area. Next slide. So I'm quickly going to touch upon training. And of course, we know how training is related to practice and related to self-efficacy. Communities talked about what areas of training they thought were a strength and which ones need improvement. You can see that suicide prevention and mental health were seen as strengths, whereas maybe lethal means counseling, gatekeeper training, and military cultural competency needed a little bit more improvement. So about half of organizations agreed that limited knowledge among staff was a barrier, and about 2/3 agreed that training gaps were a barrier for preventing suicide among high-risk SMVF. Next slide. So I know there's a lot of data here, but I just wanted to point out that if you look at the left column, that less than 25% of staff within an organization receiving training by topic, you can see that about 60% that's the case for lethal means counseling. So there's a big gap there. And then we look just generally at suicide prevention training. We have a quarter saying that less than 25% of their staff have been trained in suicide prevention. So this, generally speaking, there are gaps in training that we really should focus on in order to build our capacity. Next slide. So we have a few brief recommendations. We have a lot more detail on this. I know we're running at time here, but it's important to provide guidance to improve partnerships and collaborations. Specifically talking about what are people's roles within the care continuum. A lot of agencies and organizations don't necessarily realize they have a role, and I think making that clear and how they can fit into this work is important. We talked a little bit, actually, we heard some stories about it earlier in the presentation, but about having templates and information sharing available. So resource inventory templates that you can provide, examples of MOUs and information sharing protocols. It's also important to raise awareness, so of those local crisis services, of crisis text line, and of course of 988, the importance of lethal means safety and how to approach that. And then just the standardized screening and routine in emergency medical settings. And then, of course, providing training and TA to professionals serving SMVF. So we know the importance of training, and in all the implementation work that you may have done, that I've done, it's not all about training, and that if there's not the proper implementation support and TA provided, that the training might not be as effective. So it's really important to provide that targeted training, TA, and implementation support. Next slide. All right, so that's all I have. I appreciate everyone's attention, and I'm open to answering questions with the rest of the group.
Thank you so much, Dr. Harris. Really appreciate that breakdown of those key takeaways from those 24 communities. When you looked at the map that you showed at the beginning of your portion, you can see that those communities really spanned from coast to coast. Yet and still, there were a number of commonalities that rose to the top from those communities that participated in the SIM workshop. So thank you so much for breaking those down and sharing those with us. Wanted to get into a couple of kind of broad overall questions that came up a number of times. One of those questions was related to the slides that were shared here today, as well as whether there would be a recording. So for everyone who is registered, they will receive a follow-up email at a later date with the slides and with the recording of this webinar. So thanks for asking those questions for those who did. There were also a handful of questions regarding additional opportunities for learning. Things like technical assistance around upstream suicide prevention efforts and not just the focus on crisis. Things like hearing more great information from states, like the information that Brandy has shared from Virginia. And perhaps Dwayne can help me by putting the TA Center's website in the chat to everyone. But the Service Members, Veterans, and Their Families Technical Assistance Center offers lots of different types of technical assistance. And you can view the website that Dwayne just put in the chat to find out more about upcoming opportunities for different learning and technical assistance. There were also a few questions regarding the SIM solicitation process that Don Harris spoke of early in the webinar with the due date of November 30th. Dwayne already put that solicitation application in the chat. So that is directly there for anyone whose community might be interested in applying by that date. And there were some follow-up questions that I actually want to turn over to Don. There were some general questions about what would make a community a good candidate to be selected through the solicitation process. So Don, do you want to tackle that one?
Sure. And there were some questions in the Q&A that were somewhat related to this as well. Asking about what types of communities we've worked with in the past. And I could say from, high population urban areas to very rural areas across the country we've worked with. So in terms of the type of community, rural, urban, U.S. territories, et cetera, is fine. What would make it most ideal is being able to convene, having the ability to convene a group of individuals from across the community who have the authority and responsibility, and of course the passion to work toward this effort of preventing suicide among SMVF. The focus, of course, is on crisis system, being the crisis intercept mapping, but there are a lot of partners that are involved beyond what you think of as traditional crisis response. So again, going back to the model, there are, veteran service organizations that have a role to play, folks from local hospitals, shelters, homeless and housing shelters, educational institutions, as well as crisis stabilization units. So and local law enforcement. So the ability to convene those types of folks in the community is probably one of the primaries. We work with folks in terms of looking for data collection, certain types of data. We can work with that. I guess the key is having the will of some of those important partners and having the passion to develop some initiatives to move forward.
Thanks so much, Don. Appreciate that. Speaking of collaboration, I know that was one of the factors that Dr. Harris discussed in her presentation, the facilitators of collaboration and obstacles to collaboration. And a question that we received in the Q&A, there were a number of questions related specifically to coordination with the Department of Veterans Affairs, with local VAs. And hoping that Brandy can speak to that from the perspective of being on the ground.
Thanks so much, Stacy. And I definitely appreciate the question. So, we went after with our Crisis Intercept Map team, the VA community-led structure. So we tried to identify a local VA staff person, usually suicide prevention team member, but not exclusively, and then a community-led champion for the team. But so what I would say is sometimes it can be hard to know where to start with a larger VA, especially to collaborate. But your suicide prevention teams are incredibly collaborative. So the suicide prevention coordinator, there can be a single or multiple suicide prevention coordinators. These teams have grown by leaps and bounds over the last few years. So they truly have pretty awesome capacity at local VAs now in suicide prevention. And we find them to be really, really collaborative group. So, and it's good to make this connection regardless of if you pursue the SIM model, because suicide prevention coordinators have just a great portfolio for training and resources that they can provide to your work, for a variety of things. And then this collaboration is going to get even stronger as VAs bring on community engagement partnership coordinators. This is another suicide prevention team member, or called CEPC for short. And these team members are more strategic and community coalition builders. So you have suicide prevention coordinators that often have balanced identities between direct services provision and community outreach. But CEPCs are just about community. And so at the Mayor's and Governor's Challenge team levels, we found CEPC positions in VAs to be really, really helpful allies. So I think between your mental health team members at your local VA, suicide prevention clinical team members, and or that strategic position called the CEPC, I think those are great places to start. And we've definitely noticed really good collaboration with local VAs with those champions. If you're stronger on the peer support side, and peer support's really important to your local action, we often use a position in VA for partnerships called a local recovery coordinator. And most of these team members you can find under the broader mental health office umbrella.
Thanks so much, Brandy. We received a question kind of early on in the presentation about suicide data and groups of people who are at risk. And I'm going to read the question and ask Dr. Harris to follow up on this. The question was, do you think our count of suicides is accurate given the high number of accidental single vehicle crashes, gun discharges, and overdoses? Also with the stigma surrounding admitting to death by suicide, and is there a considerable difference among the reporting areas?
Yeah, I mean, there's definitely an underestimate as a result of those. It's difficult to classify death as a suicide. Like, a number of things have to be in place, and a lot of times it's those deaths that are classified that way have a suicide note or associated with the suicide note. And there's only a suicide note with a small proportion of suicides, about a third of them. So there's a lot of misclassification, particularly with overdose being classified as unintentional versus intentional. And when we see, like, we're all aware of the opioid crisis and the increasing numbers of opioid overdose deaths. Those that are reported are actually reported that are both intentional and unintentional for drug overdoses. So we see those high numbers. And then, so you pull out the intentional ones, the numbers are lower. But there's a lot of those that are classified as unintentional that are very likely to be intentional. And in addition to that, there's also the what's called motivation to live, or a low motivation to live. So they don't necessarily have an intention to die, but not really a low motivation to live. So there's a lot of connection between those that have risk for overdose versus those that have a risk of suicide. And there's a real opportunity to figure out what those shared risk factors are and to be able to improve upon our screening protocols so that we identify those individuals who have a low motivation to live, because some of the suicide prevention best practices could be useful in addressing the issues that we're having related to the opioid crisis. Because all of the things that we are doing to address the opioid crisis, we're still seeing that rise, and we're at the peak numbers at this point. So I think we need to improve in that area, and I think that the suicide, as a public health problem, is larger than the numbers show.
Thank you so much. I often say that when we talk about data like this, we're not just talking about numbers, we're talking about people. And I think what's coming up here is that it's really important to cast a wide net to anyone who's experiencing any sort of despair or hopelessness, whether it's related to substance abuse or mental health or what have you. All of that is a part of prevention. So thanks for speaking to that piece. Similarly, there was a question about, is there a method that slows down the a kind of transfer from helplessness to hopelessness. And I'm going to bring a question to you, Dawn, because this question just put me in the frame of mind of Intercept 1 of the SIM. And I'm wondering if potentially you have just, maybe a couple of examples of ways that communities have closed the gaps for Intercept 1, whether it might be related to 911 or 988 or any sort of primary care or any sort of place where someone may be where they're experiencing helplessness or hopelessness that might not necessarily be identified early on without closing a gap.
Thanks, Stacy. And I actually think that Dr. Harris-Brett may have more knowledge about this space of helplessness and hopelessness. But to answer that question, in terms of what some communities have done regarding this particular space or this particular issue, is ensuring that, especially for this particular process, SMVF, ensuring that veteran peers are incorporated at every stage, every intercept in the process. So taking a look at where veteran peers, building that bridge, folks that have lived experience are incorporated in some of the clinical settings or have some attachment there, in educational settings, or at least some military cultural competency to understand and build that bridge. And I would say the more touch points we have and the faster we can build that connection, the quicker we can address that sense of hopelessness and get people to the appropriate level of care. But I will ask either Brandy or Brett if you have anything to add to that.
I think there's also the importance of high quality care with trained clinicians, because when someone is identified, they go into care, and hopefully the care that they receive is effective and they feel like they've been cared for and understood, and also get effective treatment. And then they're also kind of seen through that transition of care, because if they're not happy with the care that they receive and they get discharged, they're feeling like this is the best level of care that I received, and I didn't like it. There's, of course, hopelessness at that point. So I think it's really the importance of high quality care among clinicians that care, that have empathy. And I think one of the key things of the safety plan that has gotten added in recent years is kind of the more hopefulness approach, kind of like reasons for living, to include that on the safety plan. So that it just taking a hope, putting the hopeful lens to it, and taking a hopeful approach rather than more of a negative, deficit approach.
Yeah, definitely so important. Messaging, as well as those peer connections that you all spoke about, and quality care. Brandy, do you have anything to add as we're in the final minute of our time together?
No, great responses. So just for us, it's, using every opportunity to promote hope through lived experience, shared experiences, and of course that 988 number close to all of us, and then offering when someone is in a tough moment to call with them. So it might be hard to go and do that on their own, but can I call this number with you is often successful in our direct services work. Thank you.
Thank you for that, and thank you all so much for really sharing your passion and dedication to the SMVF community, and helping others learn about how we might partner together and really make an impact for the military and veteran community that might be at risk for suicide. So with that, we will go ahead and close our session for today. Thank you all for joining us, and enjoy the rest of your day.